Okay, good morning, everyone. My name is Rob Johannes. Pronouns are he, him, and his. I am a member of the board of directors of the Canadian Alliance to End Homelessness, so thank you for being here on behalf of the board. When I started doing this work 25 years ago downtown Eastside Vancouver, I didn't have to wear glasses, so these problems are long-standing, and that's an issue. So we talk a lot about truth and reconciliation while royally botching pronunciations of Indigenous nation names. So I would really like to open our session more consciously and purposefully. So if we could take a moment, plant both your feet on the ground. On the ground that is supporting you. Feel free to close your eyes if you're comfortable doing so. And I would like to start our time together by acknowledging that Ottawa is built on the unceded and unsurrendered territory of the Algonquin and Anishinaabe Nation, who have been its guardians since time immemorial. Let us honor and celebrate the many First Nations, Métis, and Inuit peoples across Turtle Island as this land's traditional knowledge keepers and courageous leaders, past, present, and future, especially in the fight to end homelessness, which is our purpose for gathering here over these few days. We are mindful of broken covenants. We strive to make this right in all our relations with the land and with one another. Here in Ontario, we are all treaty people. Many of us have come here as settlers, immigrants, and newcomers in this generation or generations past. I'd also like to acknowledge those of us who came here forcibly, particularly as part of the transatlantic slave trade. Therefore, I honor and pay tribute to ancestors of African origin and descent. And furthermore, in recognition of the 10,000 plus lives that continue to be uncovered at 139 residential schools across Canada, many of which have not yet been excavated, and the last of which closed in 1996, when probably most of us in this room were alive. So this is not history. This is something that we are living with, and in many cases benefiting from the consequences and exploits of these institutions. So I ask now, before we proceed with our session, in honor of those lives lost and the responsibilities we all have moving forward towards truth and reconciliation, that we hold a moment of silence. Thank you so much, everybody. I'd also like to recognize that I am joining you today from my new home of the Council of Three Fires in Illinois Nations Territory in Chicago, Illinois. And I must say words I never thought would ever come out of my mouth this morning. I was excited to go to Tim's. What the fuck is going on? So this session is social medicine meets people where they're at. If that is hopefully the room you were coming for. I know room 204 was a little odd to find. It went like 2, 3, 5 over there, and then 1, 2, 12 over there. So I'm glad you're here and we're all here together. During this session, we will look at the intersection of medicine and homelessness. Medical professionals are pivoting to provide ongoing health care in the community long after discharge and engaging with lived experts and co-designing programs that meet people where they're at, whether that's at the hospital, in the streets, or in shelters. I will have the speakers introduce themselves as they go along, because I find that it can be a bit redundant when I do it, and because especially in this work, a lot of our identities and who we are feeds into what we do. So those things are just so connected. And this is a superstar panel, I must say. And it's very great to see some familiar faces from the work being done in Toronto that I did for 10 years with many of you. I'm reminded of, before we turn it over to the first speaker, I'm reminded of a time when I worked in a transitional housing program in Toronto, probably 10 or 11 years ago now. And there was one person that lived on the floor in the program that was on the caseload. And we were having a hard time just sitting down to meet and figure out, okay, what are we going to be doing together? And how are we going to work together over the course of the next year? And it reached a point where I said, okay, I'm just going to go. And I pounded on the door and I said, okay, we need to meet right now. Because he was always not ready. I'm not ready to meet. I'm not ready to meet. And if this didn't happen right in front of my eyes, I wouldn't have believed it. But he took a bottle of Smirnoff, this big, cracked the seal, and right in front of me, downed it all in one go, and then put it down and said, I'm ready to talk. And I just passed 9 years in recovery, and I didn't fuck around. I did that. I spilled more drugs than most people did. But even for me, I had to have a moment of checking myself and saying everything that is true and real for me, I need to leave that at the door, and I need to meet him where he's at right now. And that's why this work that we do is so important. When I first was involved in opening the first consumption site in Vancouver 20 years ago, we had this conversation, and we're still having this conversation now about the spectrum of harm reduction, and everything falls on that spectrum. And particularly at a time right now where the provincial government is saying no supervised consumption sites and everyone should just be going to treatment. Well, you can't go to treatment if you're dead. We're just trying to get through. We're talking about members of our communities who the physical withdrawals can kill you. We're not even at the point where we're having the conversation about treatment yet. Maybe we can get there. Right now, we're just focused on getting through the next hour, the next 24 hours, the next week. And that's the wonderful work that our panelists are doing here today. So I'm going to turn you over to the wonderful Rene Adams, and someone who probably needs no introduction in these circles, Dr. Andrew Boozary.
Good morning. Rene, do you want to go ahead? So do we just pull up? This is like my favorite part is the tech aspect. So Rob, you left me with, oh, it's up here. So we'll just hit a button. Just hit the space key, yeah? Okay. Rene, you want to start introducing yourself?
So good morning. My name is Rene. I'm a part of the advisory panel for social medicine at UHN. I'm also a descendant of the first peoples of Southern Africa, so I acknowledge my privilege of being able to present here today on this lens.
Thank you, Rene. I'm really honored to be able to present and talk about our work together that Rene and I have had over the last many years. And the Gattuso Center for Social Medicine has been a 5-year undertaking that we have this year to be able to speak to some of the work, some of the social medicine approach, and I think some of the ways that we've been looking at co-design and some of the projects in place. Something is beeping, but we will avoid that as well. I'm hitting the space key.
Arrow.
Hey, Rob, how's it going? Your glasses. This is the good part. Yeah, it's a good part of going.
Sorry, first session of the conference again. We're working on it.
You're right, I'm not sure you're set up. Where's you?
And everyone, please give a big hand to Josh.
Josh, you're on. I'll stand.
Okay, so thank you. All right, we'll just jump right into the first slide, if that's okay. So, for many folks who may be from Toronto, and I should introduce myself, I'm a primary care physician and executive director of the Gattuso Center for Social Medicine. And I was born in St. Jamestown, Toronto, which is a closer view of what it is like, and it was the most most dense 1 kilometer of diversity in Canada at the time that I was born in the coming years. And when we talk about the social medicine approach, I think people like to think about what do we mean by the social determinants of health. And I think it's a pretty academic term and an esoteric term when it's something that I think as children we really understand and see. When you look out, and I remember this growing up at 135 Rose Avenue, when you're in St. Jamestown, there's no green space. There's a lot of density. There's a lot of resilience, but there wasn't a lot of opportunity. And you could tell it by looking out your balcony into Rosedale, which folks may know a little bit about leafy Rosedale. There's a lot of green space. And these are zoning and policy decisions. And there's not a lot of density, but there's a lot of land. There's a lot of space. And these ideas around what drives health, I think, are really obvious and innate to us even as children. And this is really a lot of the work that we're undertaking together at the Gattuso Center is how do we bridge some of those gaps and how do we actually integrate those things that we know of where people live, the air that they breathe, their opportunities are really integrated in the way that they can define their own health and well-being. And this is some really great work recently from the local, which was able to publish some recent data of life expectancy and maps. So the one thing we really love maps. I love in terms of how they can help tell this story. So that's where I was born at a life expectancy of 77 years. And there's only one street, Bloor Street, which separates Rose Avenue from Rosedale. And if you go right across that street, there's a 6 or 7 year gap. And so it's not issues of geography. This is really about the social determinants or the moral determinants of health. Rob is telling me to speak more closely into the microphone. Thank you so much, Rob. And so, well, then we'll both, Rene and I will come in close on a co-microphone usage. So when we talk about the social determinants of health and social medicine, it is in no way new. Like we have to be really clear. This is one of the original publications that this map, does anyone know what map this is, what city that is? It's a bit obscured by the journal article, but there's Roman numerals. Good guess, close. Paris, very cultured crowd at CAEH. And so Paris is right on the arrondissement, the Roman numerals, is that those neighborhoods, there was a young physician back at the time, Louis Rene Vermeer, who was able to see in 1837 that depending on which neighborhood, whether it was a wealthy or it was a poor neighborhood or arrondissement, was the biggest driver of whether or not people lived and how long they lived. And it was more powerful than anything that they could do in the surgical, in the operating room and in the surgical department. And he found that the effect was so powerful that Vermeer actually left surgical practice and became an economist. His view is this is really about the pathologies of poverty. And so we've known about this in terms of Western medicine of this publication almost over 150 years ago. But we've also known about it in Canada. And so the folks familiar here is we're in Ottawa with the Lalonde Report. So this is the 50th year of the Lalonde Report. So we've known about the social determinants of health that's been published in Western medicine for over 100, close to 200 years ago. But 50 years ago, this is one of the most important policy papers that was put forward about the social determinants of health or what actually makes people healthy. One of the things I find when I assign it to students, which is really not just the vintage retro cover that gets people surprised, is it's the Minister of Health and Social Welfare. So there's this idea of integration even 50 years ago about the social aspects that really drive health. But when Rene and I have been talking about this and we look up the road, in Toronto, there's a Ministry of Health, a Ministry of Mental Health, a Ministry of Long-Term Care, a Ministry of Community and Social Services, all ostensibly trying to help and care for the people that we serve. And one of the things that Lalonde put forward actually in 74 is that they were really nervous about housing. They were also really nervous about the fact that universal healthcare alone was not going to be enough. And this was about 7 years after Medicare was passed in 1967. So this was published in 1974. And Canada was actually at one of the leading countries on the social determinants of health. The UK did not publish anything about the social determinants until the Black Report in about 1980, and the US was about 10 or 20 years behind. And so how did we do with Lalande's advice? If Lalonde was worried in 1974, I think this is one of the most powerful graphs and set of data where close to 20% of all housing stock was social housing in 1974, 1972. And we've seen this very deliberate atrophy of access to social housing or social housing as a stock, which is what all of you and your leadership are trying to push up against, both for your clients and the lived experience aspect, when it's less than 4%. And it is so staggering, this decline in social housing, that even Scotiabank, which is not exactly a left-wing think tank, put out a call to say we need to double the amount of social housing. And even if we doubled the amount of social housing right now, we would only be at the OECD average. So we are well behind our OECD peers. And on Lalande's advice, I'd say call this the health spending paradox. We did not follow Lalande's advice, which I think is no surprise for anyone in the room. This is a terrific paper that looked at health versus social spending. So look at things from education to housing versus more doctors and nurses spending, which is obviously both really important, but we saw a flat line in terms of the provinces on social spending around a 30-year period between 1981 to 2011, and healthcare spending that has gone up more dramatically in that period of time. Some may look at this, and some have, and said, well, the reality is we're paying too much for healthcare. We need to shift it towards social spending. If you actually look at our net spend of public dollars in both social and healthcare spending, we again are well below the OECD average. So it's really a case that we need more public investment in both to have the outcomes and health outcomes if we're serious about a social medicine approach. And this takes us here to today in 2024. So we've gone through Vermeer, we've gone through Lalonde, and 50 years later, the realities are that we don't really need AI or machine learning. We can have a good sense of predicting your life expectancy or how you will fare in terms of your healthcare treatments more by your postal code than by your genetic code. And that's really on average what we deal with from a population level. And that's been really the impetus of the Gattuso Center for Social Medicine. Not surprising at all. Again, this is the reality in Toronto. I know this is a national and international conference. We're dealing with wait times of over 8 years for people to get access to social housing. That's why we call it a terminal condition, because people who I serve were more likely to pass away before they get the call for housing.
Okay, so yeah, it takes a long time to be on the social housing waiting list. Is anybody here from the region of Peel? So I'm fortunate enough to have a subsidized unit through the region. But I can never feel 100% secure, because I remember back in the early 90s, Toronto lost a lot of affordable housing units through cuts to programs. And the first people to get cut were the people living in private buildings that had subsidies. So that's always in the back of my mind, that I could end up homeless again one day. When I moved into my first housing unit in Toronto, it didn't take very long. It was a matter of a couple of months. But moving to Peel Region was a 12-year wait. I can only imagine how much longer that wait is now for people who are just getting on that list. And in the meantime, people get sicker. They lose social connections if they have to be moving around a lot. Their kids get discombobulated when they're having to change schools all the time. If they're fleeing domestic violence, the kids are subject to this new stressful environment of a shelter, being shuffled to daycare that might be new to them, being shuffled to schools that might be new to them. And it does have an impact at the end of the day, just like physiologically, because of the stressors that these kids are under. I experienced that with myself, with my older child having to flee in the middle of the night. My child was used to a different schedule when it came to eating, and unfortunately it didn't mesh with the shelter schedule, so there was a lot of conflict. between me and staff. And it caused a great amount of stress on my daughter as well.
Thank you, Rene, for sharing, these stories. And I think the realities are that I know that you've been advocating for deeply and strongly is that it is getting worse and worse. And I think those are the realities that are in the room right now across the country. And these are the realities that we've known for a long time at the hospital level. And I think we've talked a lot about the social determinants of health. And I think we've heard about these stories. And Rene, family, and many, far too many in the country are still grappling with in many serious ways. We've not really acted as well as we can given the resources that we've had. I think those are the realities of large academic health sciences centers. We have published and written about the social determinants of health. But this is a call a few years ago from Don Berwick, who's one of the sort of OG social pediatricians and social medicine docs in the US, who really made the case as well that we need to be acting on these social determinants of health. And how can large hospitals or large healthcare networks that do have resources and various evidence really leverage that to try to start to move the needle on the social determinants of health. And so this was really where we started UHN with respect to the data. The data is really, really important in formulating both the Gattuso Center for Social Medicine and this work. Let's go break one. Sorry, that was my trigger figure. I apologize on this. And so when we looked at this, and we'll go right to Rene in a second, is that we had 100 UHN patients with no fixed address in the last year that made over 4,000 emergency department visits. And that's not because people want to be there. It's because people, are getting sicker, but there's also less and less supports. And the emergency department has really been functioning, as Dr. Snider and many have been working, as the last thread of the social safety net. When we started this work in 2019, it was about 234 people making up over 15,000 emergency department visits. And so leveraging the hospital data, be thinking of how do you take a data-driven approach to social medicine in this work. And I think the data is a really important piece of this, but the part that we're so fortunate and grateful is to have Rene's leadership, as well as Opal and Michael Armstrong, which we'll get to, as an advisory council of how you marry the data and lived experience to drive these programs, which we'll touch on briefly. And Rene, to you. Sorry, I was a bit early.
So myself, Opal, and Michael all have experience using the healthcare system a lot, and also in being activists in different areas when it comes to poverty reduction and the creation of affordable housing. I was actually in my teens when Eva Smith herself, namesake of Eva's Place, pulled me out of class to go with her to Mel Lastman's office to get support to build Eva's Place. And within 2 weeks of that time, and after Mel declaring that there were no homeless people in North York, a woman was found frozen to death. So it's hard to forget that. I've experienced homelessness in my life as a teen, as a young adult, and as a mother, like I mentioned before, fleeing domestic violence. And I use all of that experience that I have, even negotiating the healthcare system, to advise, to say, have you looked at this thing this way? Have you looked at it from this angle? Have you looked at it from that angle? And I believe it's helpful in helping other people understand that there's more to think about than just housing. It's not just bricks and mortar. It's successful tendencies. It's learning new life skills if you've lost it from being on the street for a long time. Those all matter when it comes to generating health and to recognizing your determinants of health.
I'm so very grateful to Rene, Michael, and Opal, who definitely keep the team honest. I think every week in the meetings, and again, from an advisory, but also from the accountability perspective, which I would say is really the piece that we try to move forward. I know that Rob is looking anxious at the back, given our tech. No, he's now telling me we're great on time, which is wonderful.
Yeah,
okay. So this is to give just a highlight overview of the Gattuso Center for Social Medicine, of the programs. Been mentioning about elements, as Rene talked about, housing, but there's also everything from food insecurity to work in the emergency department with peer workers. I know the neighborhood group has been here. There's the housing initiative with Fred Victor that has been in the room, and then as well the Stabilization and Connection Center with Parkdale Queen West, Intercity Health Associates, and TNG as well, and the paramedics support services. We'll try to really fly through them with less than 40 seconds each, given the time constraints. But Renee and I are happy to connect offline on further details of these programs. I wanted to highlight that we are trying to touch on everything from loneliness to food insecurity to the most structural determinant of health, which is housing, which we'll have a little bit as well. Here we have started with the peer worker support program. This was Mia, who started in 2020 in the emergency department with really the support of the Gattuso Center and Gattuso Foundation with the neighborhood group to have individuals with lived experience of drug use to the stigmatization that happens in emergency departments. And I know we'll hear a lot in a few days how EDs are not safe spaces for people who are unhoused. They are not inviting. There's harm. There is stigma. And this is really, I think, a lot of the work over the years to try to rebuild some trust with peer support workers who work alongside physicians, nurses, and social workers. When we started, there was a lot of apprehension. There was a lot of trepidation around, can this work in having regulated with non-regulated? How do we ensure the sharing of data? And I have to say, it's one of the programs that Rene and I get written the most about to make sure there's sustainability of funding from the same frontline workers that had some apprehension early on. So I think it really speaks to the success and also the number of patients and clients and families that peer workers have really continued to work with over the last few years. We've seen this evolve into the social medicine navigator and community health worker program. Again, the idea around trying to build trust with individuals where they've been marginalized and hospitals have not done a great job of trying to rebuild that trust. And looking at different healthcare workforces to do that beyond the more typical healthcare team. I would say this was a huge learning for me through COVID vaccine community efforts that many of us were involved in. It was actually not the doctors and nurses I found that people were willing to want to talk to and trust. It was community health ambassadors. And I worked really closely with many of them throughout the pandemic response. And it was really clear for us that at social medicine, we wanted to see this model become more embedded, both in the hospital, but out where people live. And I know that many programs here have great outreach and community health worker programs. I think the idea for us is how do you have it both in the hospital, working closely with community, but also integrating this into the electronic medical records was a major piece of work to see that come through. So this is not surprising. I know that there's some terrific colleagues here who have done some work around housing. We talked about it being the most structural determinant of health. And I think the argument that we've been putting forward is that failing on human dignity is very expensive from the human cost perspective, but also the financial cost, which we'll get to shortly. And I know that we'll look at the evaluations, but I do think it speaks to, it's a bit of a sad story that we've had a randomized control trial to figure out if housing really impacts health. We had positive results and we're still sort of in the stance of what kind of evaluations and further data do we need? And I would argue COVID was a pretty awful natural experiment. There's some great work from Lucy, Richard, and others that showed people who are unhoused were 10 times more likely to die. So as a researcher, I obviously think the data is super important, but I think we've got a litany of data that speaks to how dramatic the outcomes are if we don't have housing. And so this to Dunn House is our response at UHN Gattuso Center. And this is the work with Fred Victor, the City of Toronto, United Way, where we were able to leverage a public parking lot to build 51 housing units. And as Rene mentioned, Opal and Mike Armstrong worked really closely with Pavey and many folks who are doing this work of setting up the care model of what kind of supports need to be there that is a bit augmented or actually quite unique in having both healthcare and social care right on site. Some of the elements of the amenities, I think the big piece I would say is that we heard from people with lived experience, it needed to be pet friendly. And I'm really thrilled that it is a pet friendly residence for people's family members. So I think that's a big piece. And Rene, you may want to speak to some of the other parts. I know you were instrumental in a lot of the design and patient supports.
Food security is a really important issue if we're talking about people's health. So we were fortunate enough to have a partner and a local farmer who's willing to donate fresh produce every week. So that's not only for the regular food program, but also for individuals as well if they want to partake in preparing their own meals.
Rob is approaching. We have a last piece, and this is, we can again speak offline. We'll be publishing some of the playbook around the idea of there being both a really great Fred Victor team that is huge expertise, of course, in delivering the social care supports, and as well the healthcare supports of UHN, from virtual emergency department to primary care, that we're trying to ensure to addiction and harm reduction treatments on site. And I think this is the reality of where the status quo is not working. I think a lot of people have questions, and policymakers, can we afford to do this? I think the question back is, can we really afford the status quo when these are the numbers that we're currently living with or grappling with, and is coming at a serious cost to individuals living half as long as the general public. And we'll end with the last line of the Lawn report. I think it still rings very true, and it's a bit harrowing that this was the last sentence, and this is really going to be about choices. We made choices over the last 50 years as to why where we are now, and I hope collectively at CH these are the kind of choices we can will towards a better trajectory. So really honored to be here with Rene, who's been so instrumental over the last few years, and thank you for your time.
I just wanted to mention one more thing. I'm part of the Canadian Lived Experience Leadership Network. If anybody with lived experience would like to connect with us, then please approach me during the conference. Thank you.
Thank you very much.
Awesome. Thank you. That's great. It's funny you mentioned me looking anxious back there, and my former ED from Fred Victor is here. I never did this when I was working, but it's the George Costanza thing. If you just look annoyed all the time, people leave you alone. So I'd be sitting there at my desk, right? But then I got a lot of work done. So I didn't actually do that, Keith. It's all good. It's interesting that you mentioned the thing about tax dollars, and when we talk about meeting people where they're at, you sometimes also have to meet those you were trying to convince and other providers where they're at. When we were trying to get buy-in for the opening supervised consumption sites in Canada, when we would have town hall meetings or even one-to-one meetings with people who were constantly, who were more swayed by finances than by, morals and ethics. And I would have to say, take the number of long-term hospital stays and multiply that by X number of people, and then compare that to the cost of rent of a space and some clean syringes. And that's all money that's going back into your pocket. And they would say, oh, so this saves me tax dollars? And I'd say, yeah. And they'd say, okay, sign me up. I hated that I had to take that line of logic, but again, you have to kind of dispense yourself at the door and meet everyone where they're at. We'll work on their cold, dead hearts eventually, but whatever gets you in the door, then you're in the door. So thanks, Dr. Boozary. For 8 years, I coordinated a service providers network in St. Jamestown, made up of 45 organizations, and it's a very exciting, innovative model. So I would highly recommend everybody look it up. I am going to pass you over now to Carolyn Snider to talk about the Emergency Department Outreach Worker Program at St. Michael's Hospital. And also a big thanks to St. Michael's Hospital, because without all y'all, I wouldn't be here. So thank you. And Carolyn, here you go.
Thanks. It's a real honor to present today. I'm Carolyn Snider. I'm an emergency physician at St. Michael's Hospital. And I also get the title clinician scientist. And early in my career, I was trying to figure out, what does it mean to be a researcher in something that you just so deeply and passionately believe in? And somebody said, sometimes you need to find the data to tell what you already know. And that's the last thing you want to say to a researcher, but because there's no null hypothesis in that. But in fact, I think, Rob, you've just alluded to this, is so often that data and those dollars are required in order to move forward and make things sustainable. And I suspect that conversation may come up in the panel as well. I do think it's important to situate myself and who I am. I am urban based, as I mentioned, in Toronto, and in fact, a downtown Toronto girl as well. My ancestors include a German and Scottish couple who purchased unceded territory on the Haldimand Tract that was part of the Haldimand Treaty of 1784 with the Haudenosaunee. My ancestors include the son of black slaves who acquired unceded land as that was part of the Rice Lake Purchase, Treaty 20 in 1818 with the Mississaugas. And I and close family do live on unceded land. That was part of the Toronto Purchase and the Lake Simcoe Purchase. And so although I have Black ancestry, I think it's very important to recognize that I identify as white, as it is something that I did not grow up with. But I do find in reflection of that, and I share this in part because I think the intersectionality of those histories in my family are always very important to reflect upon and how they've impacted me and my families. As a white settler, I also think it's important to recognize that I benefit from the healthcare and education systems that were built upon, that were built essentially for people like me. And I work within a Catholic healthcare institute, and I, while I may not be a Catholic myself, I was born in church as part of its role, and I acknowledge the church's role in the significant harm that it inflicted on Indigenous children, families, and indeed communities across this country. And so I believe very strongly in truth and reconciliation and the mission of our healthcare in trying to understand more and continue to do what we can to better commit to truth and reconciliation as organizations. Today, my goals and objectives of this are really to describe the development of our ED outreach worker program. I benefit in the sense that I'm really centering on one of our programs. I will tell you a bit more about the emergency department at St. Michael's Hospital and what we have there already, but I wanted to really drill into the one program today and tell you a bit about what we've learned so far and what our future goals are and where we're going with that. For those that aren't familiar with St. Michael's Hospital, we are in the downtown urban core of Toronto. We're a block from the Eaton Centre, for those that have visited and often spend time there. Over 45% of visits to Toronto EDs are actually at St. Michael's Hospital for those who are experiencing homelessness. And over 20% of our patients each day are from people experiencing homelessness, and obviously at certain times of the year, many, many more, especially overnights in the winter times. We are very blessed with many social medicine supports in our ED, and I did spend 8 years working in Winnipeg Health Sciences. Also had some great supports, but really coming back to St. Michael's Hospital for me was really important. We have social medicine, social work, 18 hours a day, 7 days a week. We have an AD Indigenous health worker. We have community support workers 24/7. They are essentially peer workers that work out of our Rotary Center, which I will show you in a moment. We have addictions worker. We have a mental health support team. We have geriatric emergency nursing. And in 2021, we developed with many community partners the ED Outreach Worker Program, which will be the focus of our conversation today. This is our Rotary Center. It actually opened in 1999, and it is an area within the emergency department where people who are experiencing homelessness or precariously housed can go at the end of their ED visit. And in that space, we have laundry and food and a place to lay down for a while. We have a lot of toiletries and things and clothing. And so we do our best to try to help people bridge that moment from your discharge to trying to engage with many of the social supports in the community. And it's for a long time has been a really important part of our program at St. Michael's Hospital in the emergency department. I, as a physician, know that they're going to somebody who has the expertise and trying to link with that. More and more, though, we noted that gap between the hospital and the city, and I don't mean just like City of Toronto, like all of the many frontline agencies within our city became harder and harder to bridge. And a part of that is the fact that all of those people that I mentioned initially weren't actually stepping outside of the hospital. And that it's very easy to say, okay, well, we've set you up with all of these things and then goodbye. And they walk out the door meeting the people, but there's so many barriers still as soon as you walk out that door. And so recognizing that, we worked with many of our community partners. Fred Victor's been noted here as one of our key partners as part of an Ontario Health Teams initiative. And we worked, I've shown some of the people that were throughout it, and there were many, many more that we got to work with as we developed a program for outreach. And in that case, really the idea is that within the, I'm sorry, some of the fonts switched from my Canva to this, and I thought I checked it all, but I didn't get all of it. Within the hospital setting, we can do some of the work, but then the outreach workers will work with somebody for sometimes as long as a year to really start to address or reconnect. When we were very conscious, we don't want to duplicate services that are in our community, but to connect with those services. And really the circle on the right bottom there really speaks to the fact that we can define all sorts of different social medicine services that we try to connect with. We also have a long-term plan, and we still do this sort of to a small extent, but would love to do more if we had the capacity to, that our community partners will call in and we'll have a warm handoff at the door, and even getting somebody to the emerge if that's what they need is difficult. And we acknowledge the big barriers that are there in our emergency department. And so long-term goals are to have a 24-hour service, and I'll talk about that, but it's going to take time and money. I'm going to tell you a bit of the data from our first 2 years. I want to acknowledge for those that are data people in the room that we had some significant complexities in collecting data, and I think that's normal. But we learned a lot from it. We used and have ended up using 3 different systems for capturing data. And despite being a data geek myself, there was, complexity on how things were defined by different workers, et cetera, and who wrote what, when, and all sorts of things went into that. So we haven't even done the stats for the p-values here. I think the numbers are most important to sort of show the kinds of work that we do. I've put some of this up here. I'm not going to read out this all, but I think if you look at this slide, you will see that it's representative of a downtown urban core space. The ages, I think, also important to see is that 14% were over 64. I'm going to call out a few of them specific to St. Mike's. The resources needed for our older population in Canada are very large and very, very difficult to access. And interestingly, we're working closely with our geriatric medicine team, who now has an outreach navigator as well. And they're noting that over 50% of the people that they become involved with, they help get them assessed by geriatricians. Over 50% will have a diagnosis of dementia. Not at all surprising to those of us that work in the room, but haven't had access to getting to a geriatrician, especially those that have a year-long waiting list. So these things are very important in terms of accessing the right kinds of support for people. At our first visit, 43% were living rough, so on the street, versus having some sort of physical shelter over their head. And 48% had no income support. Those numbers have even changed over the last year or two. And I know that this is a cross Canada issue of the ability to get somebody newly homeless into shelter or has been homeless but currently unhoused is very, very difficult. So that 43% is be much higher today. For all comers, so we saw about 170. Now I'll say that we only looked at the 165 because 5 of those participants, when we cut off the data, were still very actively involved. So we excluded them from this. Of the all comers, the median time spent was about 4 weeks. But for those that stayed with us for over 4 weeks, they were often with us for just over four months, and some much longer. But that was sort of a very common number. And again, I'm not going to go through these in deep detail, but I want to speak a bit to the importance of primary care and what we've learned from a lot of that. Primary care is so difficult for anybody in our nation to access right now. And especially, I think, for those that are experiencing homelessness. We're very fortunate at St. Michael's Hospital to have some wonderful connections with family physicians who actually have a very focused practice in this area. And so we quickly fill up their roster and find the next one. But it's about making those connections. And I am going to acknowledge now that I have some of my team here, but in particular, Pavey, who is one of our outreach workers for many years and has been stolen by Andrew Boozary's team and Fred Victor's team to be the manager of the wonderful Dunn housing. So we're pretty excited for her and Toronto, but it's a big loss. But she really spoke to the importance of making those community connections. And that's, I think, for everybody again in this room. So the part that you can't put into numbers, why those connections and the people, the individuals that you get to know, the person you can pick up the phone, and why these jobs are so important to be sustainable jobs, because that's actually a huge part of these programs. Mental health, again, and addictions, again, very, very difficult to make connections. We're fortunate with lots of resource for addictions care in St. Michael's Hospital, so we were in some ways more successful in doing that. I think mental health across the age is very difficult to access. In terms of housing connections, street to any shelter was sort of one of the things we looked at. And 99% identify that as a need, and recognizing that some of the people felt very comfortable in their unhoused space, and respecting that that's not necessarily what they want is physical shelter. And we did, remembering that these numbers are to June 2023, the success percentage of 79% was frankly very quote unquote successful. And yet there's no way we're near that right now. We moved from like the tick box tally of saying, yes, we got somebody into a shelter from the emergency department, to the tick box of who we couldn't get into to who we did. And that was under 5 last year. And this stark difference between those numbers in the last year and a half have been really quite remarkable. One of the biggest difficulties we have with these numbers is they don't match the cities, because our very wise people that we're working with know to call. The phone number is just useless waste of their time, is the way they say it to us. And so it becomes very difficult to use those numbers at the city to say, well, people aren't calling because they know there's no space. And that's pretty hard. And so we're trying to better collect that number at our space. And we try to use it for advocacy. I know Lauren's here from the city. She's seen me use this data for advocacy a lot. We have to be able to collect it to tell them what the reality is, at least that we're seeing. An emergency shelter to more stable housing. And that's extremely difficult. It takes years in cases. And so Pavey and her colleagues were extremely successful at that. And it was all about really understanding the individuals and where they best fit and finding those places. And then income support was a big part of our program. The needs were higher, lower in some cases because many people were already on it, but often it's about reconnecting them, making sure they continue it. And then if you're trying to get the connection percentage is small, but that's because it can take up to a year in some cases. Other key connections have been ID clinics, making sure that people have their basic ID. We can, in the emergency department, treat and say, well, you need to follow up in clinics or get family practice, but you don't have a valid OHIP. It's a problem. OHIP is our Ontario provincial number. I think one of the other pieces to that is when we talk about hospitals, caring for people who are experiencing homelessness. Right now, we don't have any payment in from the government if the OHIP is not valid. And so at St. Michael's Hospital, that's well over 10%, estimated probably to be 15% of the patients that we see in the emergency department, the hospital doesn't get funding for. And that funding is needed to actually pay for the people that are helping them get their ID. It's incredibly frustrating. Legal clinics, refugee settlement supports, and that has been a very big change in the last year or two. Finally, with many stories of support and of successes, we have multiple people. We have people who I've been asked, have you seen this person lately? And I'll be like, actually, they're in supportive housing now. And our docs and nurses just brighten up. It is an incredible thing for them to see the power of the outreach work at play. I mentioned geriatric care being a piece. Newly homeless young person, where really identifying what their interests were and trying to get them connected into a very focused homeless or housing situation, and developmental disability and looking at focused housing for that. important to us is that the stories of success aren't just what the politicians want or what the institutions of healthcare want, or even what our partners want, but what those with lived experience. And so in our co-design program, we have many people who are as part of our advisory board who have lived experience, but also we've been doing a PREMS and PROMS study, which basically means patient-reported outcomes and experiences. And those people are, and that study is in its third phase, where we're now collecting information on what has been defined by people with lived experience and part of our program previously as to whether we're meeting that and how do we learn from those. Very, very important. So our lessons learned, and then I'm done, I promise, are that the demand has greatly outstripped the capacity, not a surprise to any of us in here, and that data is needed to ensure sustainability. When I lose somebody like Pavey, I say to our managers, how can I stop this? And they say, we just need more and more data to try and keep building the quote unquote business plan. And that's partly why we collect data. And that it's got to be clean. We learned a lot about that, clear definitions. So those are things I want to pass on, because if you're trying to collect data, it's extremely difficult, even for me, who's like a career scientist, how quickly that. And we're thinking about ways to better collect data that would be better for self-report, but also how to ensure that ownership of data, especially around race, is one of the key ones we talk about. Avoiding bias and in healthcare is really important, and yet we need that data to demonstrate the inequity of care. So how to do that well. And we have lots of learnings and things to do. We were fortunately recently, last week, I think, got notice that we have another 2 years of funding, which is wonderful. But we continue to need to stop this being about foundations, filling in the gaps where the governments should be paying. And so that's where, did I make it close? Sort of. I look forward to questions and happy to talk throughout the conference. And Pavey is around to help answer some of the on the ground stuff as well. So thank you.
Thank you, Carolyn. I'm so anti-authority. It's odd that when I start moving, everyone's like, oh no. You know, you used to have this thing you could, I must seem such a trickster. When you'd walk around with a clipboard, you'd seem important. Now you walk around with an iPad and it's like, oh. I have been reminding the speakers to eat the mic, not just so everybody in the room can hear, but also we are live casting this entire conference. That's what the camera is there for. Usually it's folks like me who are immunocompromised that are the ones that are at home. So just want to say hi to everybody at home. And on that note, you can now in the province of Ontario get your updated COVID vaccine and flu shot. I actually just booked an appointment at the Shoppers in the Rideau Centre for this afternoon. So try and do that while you're here as well. I will turn it over to our third speaker who will be talking about building skills and advocacy with folks in our shelter system. This is Taylor and Emily. Yep. All right, there we go.
Can we wait? Where is it? Oh, you don't have to do it?
Oh,
okay.
See?
All right.
We call this capacity building.
I had people on Zoom a year before COVID. Yeah. It was like, no, I say this, I can't use
You're ahead of the game.
It was pretty fun. Our IT was like, thank God you made us do that. I don't know what. Yeah, I say I know what to do. Yeah, now I can't find the cursor. Oh, there she is. Yeah. If you name the cursor, they come.
Okay.
Do you need the bottom?
On this, but not on that. There's a way to do it.
I see.
I was told.
Yeah.
Oh, that's fancy.
There we go.
Thank you. Hi, everybody. So thank you, everybody, for being here today. We are joining you from Newfoundland, and we are both actually from St. John's. And St. John's is a urban area. We work in the downtown core, and it has a rich and diverse Indigenous community within it. We're also located on the ancestral and unceded territory of the Beothuk, and the lands and the waters in and around the city traditionally serve as a gathering place for the Mi'kmaq, And the broader region of Newfoundland and Labrador continues to be home to a diverse Indigenous people, including First Nation, Innu, and Métis, and we really want to recognize that. And we do day to day in our work, recognizing that we are working with these people and we are the settlers in their home. So myself, I'm Taylor O'Connor. I'm an addictions counselor and social worker. I actually work for Newfoundland and Labrador Health Services on an outreach team in our downtown course. We have a mobile outreach healthcare team as well as a clinic. And so that's where I work.
And my name is Emily Hearn. I'm a peer support worker with the organization LifeWise, and I work in a contracted position out of the harm reduction team, so I work alongside Taylor.
So about a year ago, we were approached by some shelter operators, and that's kind of where our conversation started. So through collaboration with the shelter operators, shelter residents who we see every single day, and our team within the downtown core, we realized that there was a big gap in some services that clients were wanting. And so we decided to look at creating a program. We ran it as a pilot, so that's what we will be talking about today. Is this is a pilot program that would foster agency and skill development, particularly the skills that those clients and shelter residents were looking for. We were lucky enough to have 2 students come on with us that were getting frontline experience, and so they were a big part of that. And I just want to recognize that we did have some excellent students working with us on this. And the program is really aimed to be run as a pilot. We did it in 2 different shelters, and it was run by our lovely peer support worker once we finished our needs assessment and put it on the ground. Having it come from a peer support lens just made sense. And then also it was co-run by a member of the harm reduction downtown health team, which is where I work. So first off, why? So what we were hearing is navigating our system is hard. A lot of people who were especially in our shelter system and were chronically homeless had kind of gotten to the point where they were seeking out a case manager, waiting in long lines to get relatively basic things that they could learn and used to have those skills done. And so they were feeling a really lack of agency. So that is our second point for doing this. People wanted to be able to do these things on their own, and they just were having a lot of people do for and not teaching them and not showing doing it with them, right? So a lot of people doing for, not with in our system, and it was actually taking that agency away from people. So we wanted to look at giving them that back and doing so in a safe space. So we work within all the shelter systems on a weekly basis. We show up. We work out of our van, but we're going to public and privately funded shelters. I'm not sure what different communities have across the country, but we have some shelters that are just houses and a lot of shelters where you're not allowed to stay during the day. So we wanted to have a space that was safe and a place to learn and heal. And then having extra support. As I mentioned, we had shelter operators reaching out to us, looking for additional supports for the people that were staying in their shelters, and also for themselves. They were becoming overwhelmed and were looking to collaborate with us.
So just running through some of the goals we had in mind when creating a project like this. So we hope to foster a greater sense of connection among the community and as well improve the overall well-being of shelter residents and any professionals or supports that work with this population directly. And secondly, we wanted to teach participants life skills. As Taylor mentioned, some caseworkers, like case managers, support workers often do the work for the peers or clients rather than showing them how to do those things for themselves. So participants were eager to learn life skills that they could take with them forever. And then thirdly, we wanted those life skills and those ideas to come from the people with that lived and living experience. So we didn't want to be coming up with those ideas. We wanted to hear from them directly what they thought was important and to really highlight their voice of lived experience. And then lastly, we wanted to provide a safe space for people to learn, form community, make connections, and find a little bit of hope through one another. And then we had just a little quote from our student researchers that kind of kicked off this project for us that I thought was really sweet. So they said, our hope is that through education and access to service, we can help those in shelter cope in times of need and remain resilient. I think that's just a lovely little way to wrap that up.
So this slide here, I'm not going to go through it just in the interest of time because I'm going to hit on all these points now in a moment. But our hope is that this is a pilot project that we did in our community, and we had really positive results. So if anybody is thinking that maybe this would be something that you'd like to try in your own community, in your own shelter systems, this is like a cheat sheet. So you can reference it later if you want or not. So our first step in starting this process was engaging with shelter operators. So as I mentioned, we had several shelter operators approach us. Our occupational therapist, Carrie Chambers, who works with us, was part of this step as well as our students. And so we were really looking at, first off, are the shelter operators actually going to be willing to work with us on this? Coming into their space, are they going to be supportive? What are their views on us coming in to try to run some kind of programming? And what do they see it looking like? So we were chatting with them about that. And then do they have the capacity? Do they have capacity on site in terms of a space? As I mentioned, some of them do, they're larger, and some of them are just houses. So we had to consider that as well. And what needs do our operators see? They might be very different if you're doing this than what the residents see, and they might have some overlap. We were lucky that there was overlap, which made program development easier. However, sometimes what shelter operators may deem kind of what they're looking for is not actually what the people living in shelters want or think would be the most beneficial. So things to keep in mind. So this was where we did our first pilot. This was a lovely, accessible space, lots of light, wheelchair accessible, and actually had a space for us to serve food as well, which was excellent. We were really lucky that the shelter operator of the space, Safe Haven, was very supportive of us piloting it there. And this was the first shelter that we did it out of. So just to give an example of space. So as I mentioned, we work with the outreach team. And so we're doing weekly visits to all the shelters. And people in our shelter system do move around. Typically, we don't find that they're, at one shelter forever. So in moving around, we've actually built a really good relationship and rapport as a healthcare team with people in our community. And we come from a trauma-informed harm reduction approach, which I do believe has helped a little bit, and also showing up being consistent. So they know that regardless of where they are throughout our downtown core and wherever they end up that night, they're typically going to see us throughout the week. We also partner with and Homelessness St. John's, who are on the van with us. So they know that we're there and they know us all by name. So it's really nice to be able to build those relationships. And it did help us, I think, in being able to approach them in terms of needs assessment and opening up that conversation with people. So I think that is a really important thing to consider. And if you're looking at doing something like this in your own community, I would really encourage you to consider who's on the ground doing the work and who has the relationships with these individuals already that could kind of start to bridge that conversation, because just walking in as a healthcare provider may not get you super far if you don't already have those pre-established relationships. So shelter residents and their expertise in creating meaningful and empowering programming was key. This was our main goal. We went into this was to really make sure that it was going to be something that they wanted, and we weren't forcing programming on people. So to conduct the needs assessment, we actually literally showed up where they were. So we went to several shelters multiple times throughout this process, throughout a couple of months. We really took our time. We allowed people to come to us and chat. It was very informal. And we really wanted residents to come and speak with us and engaging with them to find out what they felt was going to benefit them individually and what they thought, but also what they thought of the shelter system as a whole, because most people who we were speaking with, it wasn't their first time in shelter, right? So they'd been around, they'd seen what was out there in our community. So their input was crucial.
So when conducting the needs assessment, we thought it was really important to consider the aspect of providing incentive to lived experts for providing their time and work for us. So initially we did have limited resources, so our incentive provided was food and drink. But in the future, if we conduct another needs assessment, or if anybody out there is looking to recreate this style of work, I always think cash is the best option. And if your organization cannot provide cash, maybe gift cards could be a good second option. You could ask them even what gift cards they're interested in. I just think cash is best, just because then they can get whatever they need out of it, right?
Yeah. So in terms of program development, so our lovely students that we had actually compiled all of our research for us, which was excellent. I didn't touch that part at all. So we actually saw there was some overlap between what people were sharing, however, not a total overlap. So we looked at trying to create groups that would target both what the shelter operators were asking for in terms of what supports they felt would be helpful. But our main goal was put on the topics that the shelter residents brought out. So we did some psychoeducational material as well as tangible life skills. And we can, if anybody's interested, we can talk a little bit about that more. I'm getting a time warning, so we're going to speed through because we've got a lot more to cover. But we did 4 weeks as the initial pilot, and we have done this more than once. And they're open groups, so people can come and join us as they see fit. They don't need to stay. They can come and go as they would please. And if anybody has more questions about that, we'll go into it, because the next part is a little bit better than that.
So just a couple key pieces about the way we facilitated the group. So as mentioned, this was a group that was created through the voices of lived experts. So I personally, just as a peer support worker, thought it would make a lot of sense that the groups could be led through a peer support lens and have me as lead facilitator. And then, as we know, peer-led groups are often known for creating very safe spaces where people feel free of stigma, free of judgment, where they can open up and start connecting with one another through sharing stories and really find that hope that everybody's looking for. And as we mentioned before, the groups are co-facilitated by another healthcare team member. And I want to take this moment to recognize that healthcare is a system that has caused a lot of harm to people in shelter, as well as just people in general. So we didn't go into this without recognizing that. And as said before, our team has spent a lot of time building those relationships with people in shelter and really building that rapport. So we weren't just this new face going in. They recognized us and trusted us, and that helped a lot with implementing the groups. And then something that I kind of learned while facilitating the groups is that you really need to be flexible. You may go in, like I would prepare this whole thing of what I was going to say, like how it's going to look. And then I might not even get one word of that, what I had prepared out. And that's totally okay. You kind of just need to pivot and meet the need of peers in that moment. And even like, yes, there's important to have group structure, but if everybody in the group, you do a little check-in and they kind of just want to talk about something else that day, then totally cool. My goal is just that they get something out of it, right? So then just a little touching on how we promoted it. We didn't want to, well, as we know, like when starting up groups, it can be a little hard to get the numbers there. So we just wanted to focus on like promoting it in a very welcoming way. So we promoted it in a focus on having food and having a friendly chat. And that seemed to get people down just to check it out, because they could be there with their tea, snack, whatever, and just chill and listen to what we were saying. And then they can make that informed decision for themselves if they want to stay or not. And then just getting into a bit of the peer feedback and some of the positive outcomes that we had. So one peer said he really appreciated having the groups because he was in a shelter where you're not allowed to stay through certain hours of the day. So he really appreciated having that safe space to come to. And another peer at a second location said he really appreciated us coming by, providing this additional support and providing the food, because he said it made him feel like people cared about them, people saw them. Okay, and then just getting into some of the positive outcomes. Participation numbers were very strong, about average 10 participants per group. Peers expressed a lot of deep meaningfulness about groups like this and a lot of interest in expansion, so giving me more ideas of what we could talk about in the future. It helped build strong relationships between peers and shelter as well. Peer, like client to healthcare professional, the relationships even grew stronger that way too. And one positive outcome that I really didn't expect was one shelter staff member told us afterwards, he was like, you know, I was kind of snickering at you guys coming in and doing these groups because I really didn't think groups could work in shelter. And we had him eating his words because he was so impressed by our groups that he took the liberty to continue the groups every week after that. Our 4 sessions had ended. So that was amazing to see and just very validating for all the work that we put into it, and just kind of showed that what we were doing was working and people were enjoying it.
So thanks, guys. We had actually a much larger presentation, and we've got binders and books and a whole pile of stuff. So if anybody's interested, please reach out and let us know. We purposefully actually didn't go into the details of these topics, specifically because if you're doing this in your own community, really you need to go ask the people in your own community rather than kind of taking what we've done. So that was kind of left out on purpose. I know that might seem like a gap, but purposefully done. So if you have any questions, please feel free to contact us. If you want any of the other various documents, presentations that came up until this one, let us know. We've had some other people that worked with us on this, like the students, they've moved on, so their emails are not up there, just out of respect for where they've moved on in their career. But if you do want to talk to them, I can surely reach out. Yeah, and thank you. I'm going to hand it back over to you for question period.
I feel so bad being the presence that makes everyone feel they have to rush, because there's such wonderful experience and insights being shared here. As we are getting into the groove in the conference, we are a little short for questions. We have about 10 minutes, so we'll probably take 2 or 3 questions. If you could make sure you speak loudly so that everyone in the room can hear, and I might repeat your question into the mic for everyone else in the room as well as for the folks at home. So do we have any questions for any of the panelists? Oh, come on now. Someone has to have something over there in the red. Yeah.
It's
How do we do this in these times?
So I guess my comments, I think we all are struggling with that. And my theory is sometimes we have to give, like we have to play a game of it. Right? Like in the sense that, okay, my view is this is a health human rights issue. Like this is basic human rights. And that's what I was trying to get to when I was talking about collecting data, making the cost numbers. And Andrew presented those numbers around what it costs per night, etc. What we also run into is different silos. So what I run into in complexity that way is saying, let's put it in dollars and cents for the taxpayers, and let's put it into dollars and cents for our politicians. What I run into is, well, shelter is currently under the municipal governments. Healthcare is under the provincial governments. You talked about jail beds, and that's under typically it's under the federal. And you kind of need all 3 governments plus foundations plus everybody in the room, and they don't always come to the table together. And so that is the big complexity that I continue to struggle with. But I think trying to figure out the story. So I'm going to tell you the best advice I ever got was from Walter Newton, who's the premier of Manitoba, for those that know and have seen him speak. And he came up to me, when I was working in Winnipeg, and I was doing violence prevention work, which I also do with youth. And he said, Carolyn, I know you brought all those numbers today, but you need to bring me the stories. I need the stories. The people that work for me need the numbers. And he said, and the other party, they need the numbers, but some of the people that work for them need the stories. He's like, you've got to figure out who's in the room as to what they need, and you've got to find the right to tell them. And that's hard sometimes if it's not something you're doing necessarily. It's the only way I can see playing that, because these are people that are elected into those roles.
Mm-hmm.
And vote.
Say, never be silent.
Yeah.
Keep repeating your messages. Use the stories and the numbers together.
Mm-hmm.
That is so important to paint that picture, because if if they're only speaking one language, then you need to try an inroad to try and get them to understand from their language point how much they're actually losing by maintaining the status quo.
I think there's superb comments from the colleagues and panelists. I think the piece is, I think you have to, there's also the research piece on the policymakers aspect. I think that we sometimes short thrift. So, I mean, an example in Ontario, I mean, it's not a very extensive health policy platform. In the last few years, one of the main thrusts of that platform was ending hallway medicine, which folks may have heard across the country. So I think to Carolyn's really great point, there's the integrity of housing as a human right or healthcare as a human right. If the policy maker of the day is interested in ending hallway medicine, there's a lot of really good evidence around housing and supportive housing interventions upstream. So there's that alignment. I'm sure you'll find potentially, plenty in Alberta. And I think the other, in Renee's point, I think about, and Carolyn's about telling the story is really important. I mean, I sort of had this when I started out as a researcher. You feel like if you publish in a high impact journal, just by it's called high impact. So you're like, everyone's going to call me and be like, we know that we need to do this now. And like, no one calls you except like your mom, but you emailed her the article because she never read like JAMA or CMAJ. And so I think the big thing when I work with researchers and students is that you need to tell that story. So the data is really important, but that data needs to be able to tell a story. And I think Renee's point about coupling it to lived experience, which we try to talk about, I think to me makes for sometimes the most compelling sort of advocacy for what we need to get stuff done.
Mm-hmm. Yeah. Know your audience, know what their values are and how you can connect with them. We only have time for one more question. Sorry. So yes, go ahead.
Yeah, Taylor, you have another chance.
I think when we've gone in to do it, I think first off, like looking at who's going in to collect the data primarily. Do you have trusted people? Do you have people that have good relationships built up with people? I think that's where you get your most honest feedback from participants. I'm not sure exactly what types of data you're looking at, but I mean, we left it pretty open. So we didn't go in with a set list of any kind of guiding questions. We left all of our questions pretty open to people and brought it down to where they could understand what we were looking for. But I think that having the people going in being really trustworthy, it would be the biggest piece in terms of being able to respect those with the lived experience, feeling safe. And like a lot of policymakers want to know this information, and like having incentives and different things like this as well, because if we're asking them to speak with us and potentially put themselves in somewhat of an uncomfortable environment, then those would be some of the things that we've really considered. I mean, we're not necessarily going in and collecting, say, like numbers data. Ours was more wanting to hear their stories. So I'm not sure if that's helpful, but those are some of the things that we did, and maybe partnering with community agencies and groups that are doing outreach and are on the ground might be helpful. I don't know. That might not answer your question.
I think, so I've been in this for 20 years, so I'm going to say that it's complex. I think it's very important to recognize that health data, any sort of administrative data, is often terrible. To give you a sense of how data in the hospital is often collected from the emergency department, you come in and you have to answer, like X, Y, Z. So we've stopped actually collecting a lot of data, and which I think is important because it's being collected wrong. It's not kind of collected right, except what I'm driven or what I'm finding guides me are some of the things like the OCAP principles. Who owns this data? Well, those are those individuals. And so if we want to actually obtain that data in order to help further or better understand, we need the individuals who own data. which is people with lived experience and how we collect that to help design what that looks like. We need to do that thoughtfully. And I don't think we've done that well enough in healthcare. And we're social. I don't think we've done that well enough in healthcare. And that's where I sort of put a point around, like, how do we do self-report in an ethical way, but also what questions do we ask? Where does that data go? How does it get used within the healthcare journey? And it's important to me to know that socio-demographic information on a wider level. It's important for our outreach workers to know certain things because it may help connect them with certain resources. Is it important for somebody to know that information who's putting their IV in? Not necessarily, but it may also inform them as a trauma-informed caregiver. So this is very complex. I think the guiding principles of OCAP and some of the others that are out there to really think about how we collect data, who owns it, and how it's kept safe and used for the purpose is actually really key. And I don't think we have it figured out yet. I just am conscious that there's a long way to go.
So I wear many hats in the community, and one of the projects I help with is an outreach program studying the prevalence of sleep apnea in Toronto shelter systems. It's the first study of its kind. It's part of co-designing the questions that would be asked. Some of them are standard questions. So when we go into those environments, the first thing is you're connecting with those residents on some level. If you have to go back a couple of times, then so be it. And always keeping in mind the kinds of questions that we know are safer to ask for people who are participating first. But the key thing is the relationship and the trust building first.
Mm-hmm. And when you ask them, right?
I'm sorry to have to cut things off there. It seems to be the theme here, but it's a conference. These sessions are really a springboard for having deeper conversations out there. And when you go back to your respective homes to continue your work. So thank you to our panelists here. This is really wonderful. And the moderator notes say to provide a closing remark. Yikes. Okay, here's what I'll say. I'm happy to be back in Canada. It's a very heavy week for me to be outside of the US, given what's going on right now. But as someone who lives in both countries, I just want to say it can happen here. It does happen here, and it is happening here. And next door neighbors still live on the same street. So we as Canadians can't just keep looking at a fire next door and then continue to make those same mistakes, especially when our neighbors actually clean up the mess, which I trust my neighbors in my new home will deliver on next Tuesday. So just remember that when it's our turn to step up. So vote. And, lunch is going to be served upstairs in Canada Hall 1 and 2. And prenez soin de vous et des autres. Take care of yourselves and those around you, near and far, human and animal and nature. And have a good rest of the conference. Say hi out there.